Good afternoon, and welcome to the first Screenside Chat with CWD. I'm your host, Jeff Hitchcock, the president and founder of Children with Diabetes. Today's guest and our first for our Screenside Chats is Dr. Stephen Ponder, the creator and author of Sugar Surfing. Before we get started, just a couple little housekeeping items. On your control panel, there are two handouts. One is a PDF slide deck of Dr. Ponder's presentation, and the second is a GoToWebinar instruction if you have questions about how to operate your control panel. During the presentation, we have some polls that we'll be posting. We would very much like you to give us the answers to those. Also, if you have questions during the presentation, use the question area to post them. We will get to the questions at the end, and we've saved plenty of time to address all of your questions. And finally, at the conclusion of the webinar, there will be a 3-question survey that will pop up asking you about the experience. We would appreciate your feedback. And with that, I'm going to turn this over to Dr. Ponder so that he can begin our webinar.
All right, thank you, Jeff. Thank you, Jeff, and thank you Jeff, and thanks to the entire organization for having me here today. Let's go ahead and get started. This will be recorded, as Jeff said. I have roughly an hour to share sugar surfing with you. Hopefully, many of you have already heard of this, and I realize for some of you this may be a new concept. So I'm going to try to hit the middle here on the topics, and so without any further ado, I have no.
How about this? The first poll about people's connection to type 1.
Yes. Can we take that first poll, please, on your connection to type 1 diabetes, whether you have it or you have a family member with it? Please go ahead and vote right now.
The votes are coming in.
And as the votes come in, I just want to share, I have no conflicts of interest. I don't represent any companies or corporations. Also, as Jeff mentioned, there is a copy of these professional versions that I summarized in these two American Association of Diabetes journals in practice. And there are copies that are easily available and downloadable at sugarsurfing.com. All right,
Steve, here's the results of the poll. 27% of our attendees have type 1, 70% have one child, 4% have more than one, 2% have a spouse or partner, and 3% are other. So mostly parents.
Awesome. Well, I'm hoping I can address most of your concerns today. So thank you very much for being here today. Let me move my camera over a bit. This is what the website looks like if you go to it, and I just want to show you where to get items. If you want to get a copy of those handouts that I shared with you, go to Trusted Resources at the sugarsurfing.com website. Also notice that we have not updated the fact that there's not going to be a family cruise this year, and we've had to cancel some of the other workshops. Hence, this is one of the reasons we're doing this today with Jeff and Children with Diabetes. The website has a tremendous amount of free information on it. I encourage you to go there. You can purchase the book there if you're interested. I am a nonprofit. It's a 501c3, so just make sure everyone was comfortable with that. The ebook, we have a free ebook offer for newly diagnosed families with type 1 diabetes of less than 90 days of any age. Go to sugarsurfing.com or email my wife, Patsy, at the email address here, patsy@sugarsurfing.com. The themes of this chat are pretty straightforward, and it's important for everyone to remember you can't manage what you don't measure. The second thing I want you to remember is diabetes results are driven by choices and how frequently those choices are made. Sugar surfing is a skill. That means it gets better with practice. It doesn't work exactly right out of the box, and I think that some people sometimes think it's supposed to. It's not. It's something that you probably have a lot of the skills to be able to do, but you have to refine them and you have to practice them. As I say in the book, there are 3 basic virtues of sugar surfers. They have patience. In other words, they're willing to wait for things to happen. They're consistent. They have an approach to the way they do things, and they're resilient. They bounce back when things don't always work their way. One thing I always encourage my families to do is let go of the guilt monster. And, you know, whatever picture you want to use to describe the guilt monster, you have to get rid of it when you live with type 1 diabetes. Also, you have to be mindful that diabetes care must always be individualized. No two people are exactly the same. We have different lives, we have different bodies, we have different, just about everything. So individualization is the key to management. It's also important to remember that living with diabetes, just like in life in general, is about choices. The average human being makes 35,000 choices a day, which sums up to 12,775,000,000 choices a year. If you think about food, just food, and I'm not talking about people with diabetes now, but the average person makes about 225 choices each day about food alone. That adds up to about 82,000 a year. And when patients come into me to share their A1C or talk about their A1C results, I usually remind them that the A1C represents about 90, maybe to 120 days. That's 3 to 4 million choices that have resulted in whatever that A1C result might be. So I always like to kind of bounce that back and say, which one of those choices would you like to focus on? So it's a very holistic way of looking at diabetes. And I think it's important that we all keep that in mind. Here are my concepts. This is a very important right to it. We're getting right after it slide. You see a bunch of points here. And some of you might be able to tell what I'm about to show you, but as this highlighter shows, those points define a shape. That shape, as you probably know, is the Big Dipper. It's part of the constellation Ursa Major. Okay, so my point here is literally points can define shapes. Any of us who drives a car or goes on the street knows what a stop sign looks like, or a yield sign. My 3-year-old granddaughter can identify these two signs already. So shapes can carry a significance. They have certain actions or behaviors that are associated with them. As a physician, I was taught how to read electrocardiograms. As you can see here, that's a shape also. And there are elements of that, such as widths and heights and so on, that go on with the analysis and interpretation of this data, which carries valuable health information. Now let's get back to diabetes. These are all blood sugar data, all lined up in 3 columns. This could easily be put on the back of a napkin, which quite frankly I've seen before given to me in an office. But what if I take those same data and reorganize them in a visual format associated along a grid or a graph, if you will? You're going to see a couple of things I'm going to point out very shortly that are important structures. First, this one that I'm pointing out in green, and then the other one in red. They both have names. I'm going to teach you those names in just a second. A little bit more complex, but this is another real data set. And let's just rearrange these numbers in a fashion that makes some sense, in a fashion that makes some visual sense, if you will. And you can see that information gives you a whole new dimension as to what's going on with somebody's diabetes. And again, you start seeing some shapes that I've highlighted here, which I will describe over the next 50 minutes. Now, most of us are comfortable that use a continuous glucose monitoring device with looking at a very simple view of our blood sugars. And all too often, there's this impression that that's the most important thing, just the glucose level. Now, it is important, don't get me wrong. There's also been the added addition of looking at the trend line, or the trend arrow, if you will. But quite honestly, the meat of all of this information is down here along the trend line itself. And this represents a roughly 3-hour view of the data stream. And it's important to learn how to interpret that. And that's what sugar surfing is all about, is how do you interpret and make decisions about that trend line as they are occurring, as they are happening. This brings us to the whole concept of sugar surfing. It's a basic quality improvement cycle. I use an acronym called SURF, S-U-R-F. See the patterns, understand their significance, know how to respond appropriately, and follow up carefully, and of course, repeat the cycle. Now, this is probably one of the most important slides, and this refers back to the images I showed you earlier. If you look at a trend line, a CGM trend line, and you look at it carefully enough, you'll notice that there are some basic shapes that are present. And I've given them colorful names here. You can name them whatever you'd like to name them. But I have the first name, which is a shelf. A shelf is a period of stability, as you can see there. It has a width to it, like any other three-dimensional item might have a width, but it has a width, in my opinion, of about 30 points, or 2 millimoles if you're outside the United States. A delta wave is a change. It's an upward change of at least 30 points. over a 1 hour period. A drop is the opposite of a delta wave, and it's a reduction, a general reduction over a period of time, and I define this as 1 hour. And I want to point out right now that 1 hour is the core definition. You can have shorter delta waves, you can have shorter drops, you can have longer delta waves, you can have shorter delta waves. It depends on time and significance, and that'll be my next slide I'll discuss. Another structure you'll see on a trend line is a change in direction, also called a pivot. And these pivots can occur either due to the action of insulin, sometimes exercise, although many people would argue that exercise can sometimes raise as well as lower blood sugar. Carbohydrates can take a downward trending blood sugar and inflect it back up. But sometimes stress can do the same thing, although I'll have people tell me that stress will sometimes seem to drop their blood sugar. And I can point to this in my own life, that stress can take my blood sugar in two different directions. Inflection is actually a bend in the direction of the trend line, as you can see highlighted here. It's a small inflection or a bend coming off a relatively straight period of trending. And then a lag is a calculated value based on when a specific action is taken, such as insulin on the left, or say carbohydrates on the right, or you could actually substitute exercise for one of these actions, or even stress, and when you see a change or an inflection in the trend line. So just make a note that all 6 of these things in one fashion or another are going to be on a CGM trend line. I'm going to show you that during the rest of the talk here. Here's an example. Now, I've not annotated or highlighted any of this, so let me do that for you. This is what I call a classic pivot move, pivot, P-I-V-O-T. And as you can see, highlighted in red, the delta wave, which is a rise in the blood sugar, at which point in time it reaches a level, in this case, this value of 176, that a decision is made to administer a certain amount of insulin. We'll talk about how you figure that out later. And then after a small lag time of about 20 or 30 minutes, the blood sugar starts to drop, and you see the actual drop structure. And then about 2 hours later, it actually inflects or bends to a period of stability, or as I say, a shelf. So you see all the basic structures here: a pivot, a delta wave, a drop, a lag time, and another inflection over into a shelf. Now, that bracket I show for insulin duration is actually an estimate of how long that insulin dose lasted, because it did not continue to drop the blood sugar. It actually inflected to a shelf, or to a period of stability where it wasn't dropping any further. So you can use that measurement to give you a rough estimate of how long that particular dose of insulin lasted. Now, it's not totally precise and it's not always reproducible, but it will give you a range of responses which you can refer to in future decisions. Okay. Now, as I said earlier, sugar surfing emphasizes significance. On the left is a diagram of a man saying a certain amount of verbiage, which is basically trying to describe what's happening. The interpretation or the significance of that is set on the right. This person is getting low, and most of us live in a real world, and we have to look at blood sugars as going up and down, or we say it all the time: are we high, are we low, are we in range? And that's the importance of sugar surfing. The surfer makes the decision about significance. And so significance is dependent on the situation. As you can see here, these are all identical delta waves, rises in blood sugars, that occur over about a 1 hour period that go at least 30 points up. On the top, you have a value going from 190 to 220. Now, that would be significant because you don't probably want to go any higher. You probably want to take some sort of action to start turning that around. On the other hand, on the bottom, if you're going from 70 to 100, that could be due to the action of treating a mild or clinically significant low blood sugar, and that's a positive action. And so you may not want to do anything except to observe that delta wave a little bit further to see if it levels off, or inflects is the term I use, into a shelf. And I'll show you examples in the ensuing slides. Significance, same thing. It's a period of relative stability, straight line. It doesn't have to be exactly straight line. It just has to have a width to it that doesn't go outside a range that you're comfortable with. As you can see in the middle frame, 90 to 120 would be probably a very satisfactory place for many people to keep their blood sugars steadily trending. In fact, some people might be very happy between 70 and 100, as you see below. On the other hand, 190 to 220 might be a little bit elevated, and which might suggest to you I might want to do something to bring that down. There's a term for that I'll show you later in the talk called taking the drop, which is actually making that shelf go down to another shelf, a lower level, and I'll demonstrate how that works in a little bit. Now, the third major structure is the drop, and as you can see here, the interpretations may be a little bit different in regards to what you do with it. If you're dropping from 220 to 190 over 1 hour, if you're just reducing, most people would act on this by just watching this, because we like to see how much further it keeps coming down before we have to step in and maybe change that, or maybe have to even help it along if necessary. 120 to 190, 120 to 90, on the other hand, might require nothing more than just cautious action to make sure it doesn't drop much further in order to possibly prevent an impending low blood sugar. On the other hand, going from 70 to 100 to 70, that is, would most likely prompt the person seeing this to take some sort of action, either at 70 or even perhaps even before 70, to try to turn that value, that trending value up by administering perhaps a small dose of carbohydrate. Okay, so significance, again, is in the eye of the beholder. Now, delta waves, as I said earlier, can be various lengths, and they can be short and stout, like you see here, or they can be very long and extended, as I show at the bottom. And at whatever point you happen to view them, shown by this little eyeball icon I have here, is going to really dictate whether they are significant to you or not. Let me back up here. Okay, so this delta wave, which might be considered significant here, is it really significant here or not? Well, that's really up to in the eye of the beholder as to whether it is. So that's an important connotation of sugar surfing. It depends on what's happening with you at that particular moment in time, the situation at hand, if you will. And you'll see me emphasize this during the rest of the talk. This is an example. Actually, frankly, this is an example from yesterday. I showed this just to annotate. Notice that this period here is what you'd call a shelf. This is actually a small drop, and I didn't show this here, but a small amount of carbohydrate was taken right there, which caused that small pivot, which inflected up into a shelf. And then right around here at a blood sugar of about 74, a slow, gradual delta wave started to occur, which finally reached the level of 131, at which point a dose of insulin was considered and actually was given, as you can see here, which resulted in a pivot to occur, and the blood sugar started to drift down. So, but there was a lag time, as you can see, between when that insulin dose was given, in this case 3 units, and when that pivot, and that's called a mini pivot, as I use and as I describe on the website. You're welcome to refer to any of the 19 lessons on sugar surfing. I describe the mini pivot. It's in there. But this is an example, just an everyday example. Now, this is the 24-hour reading that I just downloaded a few hours ago. Notice that rise, this pivot that occurred here, it came down, but it inflected into a shelf. This is a shelf, a period of stability. And at this point in time, you can see at that point in time, a dose of insulin was taken. This is 4 units, and a small amount of about 40 grams of popcorn. I was watching a movie last night with my granddaughter, okay? And then you can see a bit of a drop occurred here, but then that drop simply inflected into a shelf, which stayed present overnight until this morning. And I had a very low carbohydrate breakfast, but requiring no insulin, but you can see nevertheless, a slow rise that occurred a little bit later on in here. So again, that's a nice 24-hour example of sugar surfing and how I look at and interpret these data. This is a more annotated, more detailed example when I had a meal at the Olive Garden. And it's important to point a few things out to people who may not realize that food can have rather late effects. Let's start out on the far left. The 14 units is just my long-acting injection. I do not use a pump. I used a pump for 35 years. I've been off a pump for several years now, and I use multi-dose insulin. So all of these, most of these examples are multi-dose insulin examples. Certainly this works with an insulin pump just as much as it works with multi-dose insulin. Nevertheless, there's a shelf, as you can see there. 8 units of insulin. Don't worry about the amount, but a mealtime dose of insulin is taken that precedes the meal. there's a bit of a bend or drop that occurs that indicates that insulin's starting to work, and then a 75-gram meal at the Olive Garden. Notice that within an hour or so, there's a significant delta wave or uptick, if you will, and because of the nature of that food, this is a bit more advanced. I'm going right to an advanced slide. I knew that it had a long-acting effect because of the fat and the protein in it, that I needed to give some additional insulin to balance out that plus the carbohydrates. And so I took a second dose on that delta wave about an hour or so later, which as you can see, resulted in a pivot and a drop, and then it inflected into a shelf. Now, you would think we're home free right here. However, if you look right here around midnight, there was a slow rise that occurred. That slow rise was a result of that meal, okay? That meal had a much longer or extended effect on my blood sugar than just was covered even with those two dosages. So that slow delta wave, and what did occur during the night, required a pivot dose of insulin, which took about 45 minutes before the lag time before it actually started to go down and inflect back into a shelf, as you can see on the far right, okay? The point of this teaching slide is that middle of the night lows can sometimes be factored back to earlier meals in the evening. Very, very important concept to remember. Those things are not necessarily separate events, not necessarily, okay? Now brings me back to a concept slide that I want to share with everyone. There are basically 9 trending patterns when you think about it, depending on how you designate high range or low range blood sugars or in range, as you can see here. Whatever the way you define them, there are only 3 configurations you can be trending. You can be high and dropping, high and steady, high and rising. You can be in range and steady, which is where we'd all like to be, in range and rising, which might mean we need to take some action before it gets too high, or in range and dropping. Likewise, we could be low and steady. Some people may be happy with that, but we may be low and dropping. I don't think very few people would be happy with that. Or low and rising, which would indicate we may have treated something, or maybe we need to keep an eye on this because it could still keep going even through the in range all the way up to the high range. So 9 fundamental patterns when you think about it. 3 ranges, 3 directions. Easy to keep in mind. Okay, I'm going to change my hats real quick. It's time for a hat change. And I think that we have time for a question, Jeff?
Well, we do. So let's hit one of the polls here. So the second one was about CGM. So let me launch this. This is asking our attendees whether they use a CGM, and if so, which.
Yes, which CGMs do you use?
Let this go for a couple more seconds here. We've got most people have voted. All right, I'm gonna close the poll and we'll show the results here. So we have 4% don't use a CGM, 82% use a Dexcom, 7% Abbott, and 7% Medtronic.
Okay, so I'm not discriminating between any brand of users. It just so happens I currently use a Dexcom, but all these methods are equally applicable to any of the other sensor systems. So I'm not picking any favorites here. Just want to make sure everybody knows that. If you're deciding on what's significant, I use an acronym called CARE. Currently, what are you doing right now? Well, I'm sitting here talking to you. You're sitting here hopefully listening to me, or maybe doing some other things around the house and listening. Anticipated. What are you anticipating you will be doing in the next 10, 20, 30 minutes or so, maybe hour? What are you thinking about doing, but then change your mind and are not going to do? That's an omission. What have you just done? What did you have for lunch? How much insulin do you take for lunch, if you had lunch, depending on what time zone you're in? So your actions as well as your omissions are important. And then, have you done this before? Well, I've certainly given this talk many a time before, and certainly eaten many, many lunches before as well. So we have experience. Those are the 4 things that rapidly go through our mind without probably ever even thinking about it in regards to how we determine significance. The visual structures I've shown you, just for the record, are called heuristics. Heuristics are very simple, efficient rules. They're visual heuristics are what I'm showing you. The delta wave, the drop, the pivots, and so on. They're mental shortcuts that help you make you able to focus on larger chunks of data rather than looking at everything individually. And so it helps you capture more information in a short period of time to make better, more effective decisions. Dynamic diabetes management is the other term I use. That's the formal word for sugar surfing. And it's based on glances. And that's going to be very, very important. I'm going to focus on that for a minute or two. Plus what you don't do, plus what you actually do. Glances plus omissions plus actions. That's what sugar surfing or dynamic diabetes management is all about. There are three prerequisites. It used to be 4. We don't have to really calibrate our systems as much anymore. We have to glance. We have to look at those trend lines. We have to sometimes be really wise and smart about how we set alarms and alerts so we're not distracted all the time and start ignoring them. And then we need to know that we need to set a steady basal effect, which I'll talk about near the end of the presentation. This is important, and I use metaphors all the time. You cannot be in control. As I said earlier, you can't manage what you don't measure. You have to glance. You have to look. You can't drive a car without looking through the windshield, or sometimes from time to time glancing at the dashboard. That has to be the first action to make things go. This is actually data from a report that was published about a year or so ago out of the UK, which was showing Abbott Libre data, because that machine can actually capture how many scans per day are done by the user. And it's important because it shows you there is a curvilinear relationship between the frequency of scanning and what the A1C result is. And it's important to note here, as I point out to my patients, that around 20 in that range, the line seems to get a little bit flatter than in between 0 and 20. So if you're wondering how often should I really look at these sensors, if you're aiming for something and eventually get up to upwards of 20 on average, you're probably at a fairly reasonable place. Eventually you get pretty wise in regards to when to check based on situational management rather than just checking at the top of every hour. This is important to point out, a very important concept. I share this all the time. This is what we're aiming at. This is a non-diabetic individual. Blood sugar max of 200. Anybody without diabetes, by definition, does not have diabetes if all their blood sugars stay within 200 at random points throughout the day. Now, fasting, it's under 100, but randomly throughout the day, it's going to be under 100. So this is kind of our playground we're aiming for with type 1 diabetes. And I want to, this reminds me of something I want to say. There's one thing I'm going to say about the COVID epidemic right now. If you have diabetes, your white blood cells don't work as well when your blood sugars are well over 200 milligrams per deciliter or 11 millimoles. They just don't kill as well, kill foreign invaders. That term is called glucose toxicity. And it's imperative for those of us with diabetes to get our blood sugars at least below 200 most of the time. It will help our immune systems and help us better fight off infection, whether it's a coronavirus or anything else for that matter. There are no two waves that are exactly the same in nature, and it's important to point this out, including glucose waves. Every day of surfing is different. The one thing you have to be comfortable with, to be able to be a sugar surfer, is not expect the same thing every day. You may get close, you may get similar, but you will never get exact. And I think intuitively you know that, but sometimes when we're actually living it, we don't always follow through on what we know intuitively. But it's important to always understand that no 2 days are ever exactly the same. And this is just a grid that shows an example from me, and you can see that there are no 2 days that are the same. There are some days, as I can show here, highlighted here, and over in some of these other frames, where I am actually having to react more than plan. My control is half of what I do during the day is what I plan. The other half is what I react to. And that's a core principle of sugar surfing. As you can see, I'm pretty good at annotating my CGM device, my app. I know that not many people do that, but it allows me to make these graphs to do the teaching for. But I put down the meals, I put down the activity when I have a certain amount of activity. I certainly put the insulin down. And the light hatch marks are my long-acting insulin. But notice on some days I may take only 2 doses, as little as 2 doses of the mealtime insulin or fast-acting insulin, and certainly my long-acting, and that's it. And other days I'll take many more. It just depends on the situation. Every day is different. Now, I show this in all jest. This is the Loch Ness Monster, or an image of a Loch Ness Monster. Of course, it's a fanciful image. But when you're looking at some of the data plots, and you can download your own data plots, hopefully most of you do this or have the opportunity to do this through your software packages, whichever ones you want to use. And these take all those lines you get during the day and overlap them and give you average ranges for the average blood sugar. And you can use that information, just like your doctors do, to identify patterns. And you can see in this case, you've got a couple humps on that Loch Ness Monster, and this is a real good Loch Ness Monster here. You got a bump there, a bump there, and a bump there. Now, the secret is trying to associate those rises with whatever behaviors are consistently happening throughout the day. That's the value of looking at information like this. This is like the old school way of taking blood sugars out of a meter and lining them up in a logbook and looking at the average blood sugar at a particular time of the day. This is a little bit different than the in-the-moment management we've been talking about, but it's important. You need to do both. This tells you from a much higher viewpoint if you need to make some behavior changes, either in your insulin dosing. It could be something as simple as timing your insulin, as we'll talk about a little bit later. Notice this is also a very interesting plot, which actually just went up to a plateau pretty much here. And I want to point something out. I would imagine that many people on this call are using insulin pumps that have the ability to control basal insulin delivery. That's what this shows. That particular pump overnight was able to try to bring the blood sugars down, but because the pump was not being used as effectively as it could by the wearer, the blood sugars went up and stayed up. And here's another example of that. This individual runs rather high during the night, the blood sugar drops, and then they sleep in, as you can see in the morning. And the pump maintains very nice control in the absence of any activity or food being eaten. But then once they wake up and start eating, they don't make some of the key critical decisions that are important for maintaining control. So while these special pumps that can regulate the basal delivery and perhaps even try to give corrective dosages are great, they still need to be used by an engaged user, as these show. And this is yours truly. This is me. This is over 90 days. This is using sugar surfing methods that I've been describing so far. So,
Steve, I have a poll about how do people take insulin. Why don't we run that now?
Let's do that. And I'm going to change hats. How many of you use pumps, and how many of you use MDI? And now I'm wearing my unicorn hat.
All right, we've got most responses in.
Okay.
So we have 26% report using Tandem, 27% Omnipod, 15% Medtronic, 4% are Loop or Open APS, and 27% are on MDI.
Oh, we got a good mix out there. That's great. They say most people can only keep up to 7 things in their head at one time. Now, I'm not going to be the one to say whether it's 6, 7, 8, or 9, but if that's true, here are some really important tips. Create a scanning routine. Make an effort to look, just glance quickly at your trend line. Make that time. The more the better. You see why. The more you scan, the more opportunities you have to act, the more opportunities you have to make a decision. The 3 or 6 hour time windows usually work the best than the 24s do, okay? Because they give you a little bit more granularity. You can see things a little bit more better. You can see changes occurring. Do that typically, as I do, before awakening. I write about this in the book. The first thing I do when I roll out of bed, or even before, is to look at my blood sugar trend line overnight to see if I see any patterns or anything that needs some attention. Perhaps before meals, and anytime I have a change in activity or stress. Now, I will say, as you do this over time, and I've been wearing sensors now for over a decade, you'll know. You'll start to recognize that something's changing. It will prompt you to look. It's an advanced skill that just an experienced sensor user will say, and many of you out there are probably shaking your head, say, yeah, I know what he's talking about. Remember, attitude counts. This information is to make you aware, not to scare, okay? You got to get rid of the judgment in diabetes. You got to get rid of the guilt. As I said, you got to kill the guilt monster. Blood sugar trends are just facts. There is no good blood sugar. There is no bad blood sugar. They can be high, they can be low, in range, out of range. They're not value judgments on you as a human being, okay? Just remember that. Otherwise, you will not be prone to do this thing called sugar surfing. Now, I put these two slides here just as a juxtaposition. I know many of you use different methods to collect your data from your CGM, and many of the Dexcom users have a wide variety of apps. I'm just showing you one of them. This one happens to be the SugarMate app on the left, and of course the standard Dexcom phone app on the right. It doesn't matter which of these you use, although some of them have quite a bit more information, as many of you know, because you gravitated away from the app itself. This one in particular, as you can see, is one little element, is it tells you the differential, in this case, the difference from the previous measurement. In this case, it says plus 18. I call that the gap differential. That's kind of my catchy phrase for it. I'm sure there's all sorts of names for people that they use it. But I use that for making decisions, because if I see the gap differential widening, I may be more prone to take action than if I see it closing. Now, I took this, and a few minutes later, notice the gap differential went from 18, a positive 18, to a positive 4. So that positive 4 meant that the gap differential is closing, so I would be more prone to wait than I would be to be worried about this turning into this monster delta wave over here. That's one advantage in some of these other various apps that are out there. I'm not going to pick one app over the other. You find one that you like to use, but this is just an example of how you can use that data to make better decisions. Sugar surfing works. My control, your control, anybody's control does not come out of a box. It doesn't come out of a bucket. It's basically the sum of our choices. Remember, I said we make 35,000 choices a day, and it exists in the moment, in the present. Okay, and what the present means is the recent past, my last insulin dose, my last meal, my last exercise, my last bout of stress, whatever, and also the immediate future, the things I'll be doing in the next hour or two. The things I've had to react to, there's just things that were unexpected, and the things I can plan. That is where my control lives. If you want an example of that, those of you that are using insulin pumps, just disconnect your pumps right now. And where will you be in 2 hours? You get my picture, okay? So control is a momentary thing. Sugar surfing itself exists at the intersection of static thinking and dynamic thinking. Static thinking is what we teach people at the beginning of diabetes. Here's your formula. Here's your ratio. Don't change it. You're not supposed to change it until you get back to see the doctor or the provider or the team or whomever, or until you're taught how to do it yourself. Everything is static and unchanging. The situation does not make a whole lot of difference, except perhaps for the carb counting. Dynamic is based on everything's changing. The world is a dynamic place. Situations matter, and that's where sugar surfing actually lives. It's a process. It's not a recipe. Hence the earlier comment is it doesn't work right out of the box. It's about making choices in the moment. It's not about what you choose to eat. Okay, a lot of people out there, and I dare say I didn't ask this the whole question, have a variety of different ways they eat, different meal plans. I'm not here to talk about meal plans. I'm not here to talk about low carb, high carb, any carb. I'm just saying sugar surfing is a decision-making paradigm. That's all it is. It's not low carb, it's not high carb, it's not any carb. It's just how you make choices based on what you're doing. Just remember that. Why this is so different now than the old days when we used to have charts and grids is that this was all backward looking. A pattern control, as we called it, was trying to predict the future based on the past. Sugar surfing is actually predicting the future as the present is occurring. So it's quite a bit different actually, and it's being able to interpret that trend line, not look back at a logbook and look at old data. So that's the fundamental difference between these two things. Remember, if you will, that there are guidelines now, or recommendations for where we want to keep our average glucose levels using our CGMs. Typically, we like the powers that be recommend under 150. They like the standard deviation, which is a measure of the variability, to be under 50. And they like to have the time in range, or the TIR, as represented by 70 to 180, remember that, be at least 70% or higher, greater than that, okay? So if you're meeting those metrics, you're doing a reasonable job. If you're exceeding them, that's wonderful. So those are the current recommendations, not just what should my A1C be. And this is not really the A1C, it's an estimate of the A1C. Many would argue it may be superior to the A1C. I'm not here to debate that today either, but it is used quite often as a proxy for the A1C. This is to point out that you don't have to be, you can be any age and do this. And I boxed my comment I want to emphasize down here. It's important to note that my wife and I apply sugar surfing techniques with quite different approaches, but with equal success. This was from a gentleman in Wichita, Kansas, who went to one of my workshops, who his wife and him learned different ways of doing sugar surfing that worked for them. So there's not just one way to do this. In Houston, a few years ago, Emily came up with Juliana. She was just a few months old, and told me that she had read the book and had used many of the principles, perhaps not all of them, but many of them, to maintain an ultra-tight hemoglobin A1C, very tight control during her pregnancy, and gave birth to a very, very healthy young little girl who's now several years old. So that really was moving to me to be able to share that. But keep in mind, sugar surfing isn't about controlling everything. It's about steering and influencing that trend line in real time. So let me sum up here. What have we learned? Sugar surfing is dynamic diabetes management. It's like I call management in the moment. Remember, process, process, process. It's not just a formula. How you take your insulin is totally up to you, whether it's a pump or multi-dose insulin, loop, any of these devices. Sugar surfing leverages dynamic thinking in proactive and reactive ways, and it's a paradigm shift, although it's becoming more and more the norm than a paradigm shift. Let me change hats, and Jeff, let's ask the next question.
Here we go. Are you already using some sugar surfing methods?
Great question. Many of you are, some people tell me they're intuitively doing this or have done it, which is wonderful. I'm more power to you. Others learn bits and pieces which were totally new to them. And I hope today is that case, that you'll learn a few new methods that you can take with you to better control yours or your loved one's diabetes.
All right. So Steve, 82% report using some of these management skills already.
Excellent, excellent. More power to you guys. I'm proud of y'all. That's awesome. That's awesome. So hopefully I can clear up a few things, especially later in the question and answer frame. Basic sugar serving moves. Okay, if I was showing you dance moves, this almost reminds me of dance moves. As you can see, that's the pivot, the insulin pivot. That's the carb pivot. This is taking a drop, and this is the reverse. This is this moving, nudging the line up. These are 4 basic moves I'm going to show you the basics of these, and hopefully the 82% of you that are doing this are already practicing these and becoming more and more effective. I see this all the time. People are sharing their successes on many of the social media sites about how they're learning to do this. Keep in mind here, this is a pivot, basic pivot. I've shown you this earlier. The decision that was made to give this insulin dose at a level of 176. Notice what the time it was. It was 4 o'clock. I will be honest with you, had I seen that here, I would have acted here. Okay, this was when I was awakened to see this. And you can say, well, didn't you hear the alarm? No, I didn't hear the alarm. Okay, I didn't wake up out of it. Most of the time I do, but not in this case. So when I saw that, I made the decision, I don't want that to keep going up or wherever it's going to go. I'd like for this to be a bit lower than 176, hence the insulin dose that was taken. This was a practice dose. I practiced these levels of insulin be administered at these heights of blood sugars, if you will. And so that was when that dose was taken, hence the lag, the inflection, the drop, and of course the duration of about 2 hours. You saw this earlier. Basic pivot, basic pivot. The next, another classic pivot, just to show you again, same example. This was actually almost exactly the same. Unfortunately, I had my alert set a little bit too high, but 6 units, brought it down. And along the drop, the decision was made because I was not happy with it dropping as fast. I took a 10-gram carbohydrate break, tapping the brakes, if you will, and to slow that down. And then over the next 20, 30 minutes, it inflected into a shell. Okay, classic pivot. Now, pivots can be very wide too. As you can see, the width of this pivot from start to finish was 4 hours. Pivots can sometimes be, an hour or an hour and a half or 2 hours, but they can also be wide pivots as well. So shapes can vary, and I put this here just to show that. Notice also that first attempt of 2 units here did not result in a significant effect. In fact, it just tilted the line, and that was when the decision was made based on the failure to come down to administer a stronger dose. Because whatever was occurring was whatever blood sugar raising effect from this meal was occurring was not enough for this to turn around. So I took another dose of 4 units. All in all, that's 6, and I had to wait about 4 hours for it to come down, which meant I had to be attentive during this time period to make sure it didn't go any further. Now, one thing I do with the alarms is I will set the lower alarm at a higher level. That 70 would actually have gone up during that time to maybe 90. So I could catch a low well before it got very, very low. That was the comment I made earlier about adjusting alerts and alarms. Shift them around to best meet your needs in the moment, then put them back to their basic levels, okay? Taking the drop, core sugar surfing method. On a steady trend line, a shelf, 200, as you can see here. Not pleased with that. I don't want to be 200. I like to be lower. I took 6 units. Again, I've practiced and rehearsed those. I've taken that amount before safely. 35-minute lag time, inflection down the drop, and about 90 minutes later, that 60 units eventually inflected back into a shelf. Okay, classic drop, 90-minute duration of effect. That does not mean that insulin couldn't be working longer. All of the people that might say, well, isn't that insulin going to work longer than 90 minutes? It might, but the functional effect, the effect on blood sugar was sustained based on whatever was happening with me, whether it's morning stress or whatever. It did not drop, and that's what matters. Whether or not the insulin is still there, I still keep an eye on it because I glance on a regular basis. Okay, another example of a drop. Okay, this one came up after a delta wave inflected into a nice steady shelf, but at a relatively high level. And this is a small drop, 2 units taken here. Lag time, inflection, downward reduction, duration of effect here is a few hours. You can see a slow drop, but it's a drop nonetheless. Okay, mini pivots are when you're doing these making these large moves, but in smaller spaces. Okay, and you can see here, this was a slow carb meal that had a late effect on rising blood sugar from a delta wave. 2 units taken here at this rise. Now this was at a blood sugar of 118. This is the paradoxical thing about sugar surfing. It's because of that being considered significant that this action was taken. Before sugar surfing, I would never have taken insulin at that level. And if I wouldn't do that now if I was using a meter only. It's because of this that I felt comfortable doing that. And of course, you can see then the effect that it had. It has small pivot and leveled back off to a shelf. Okay, sugar surfing can come across as being paradoxical to those who are not familiar with trend lines. Okay, carb pivot, the opposite of insulin. A slow drop over time. Notice that's a 3-hour, at least a 3-hour drop that occurs. 8 grams, not a full 15, was given. Notice the lag time. This was about over half an hour before that dipped down, and I was patient and I waited. Now imagine if I wasn't patient. I could have taken another 10 here, I could have taken another 15 here, then what would have happened? That. And probably many of you are very comfortable or seeing those because maybe you've experienced the same thing. I certainly did the same thing. I tended to overtreat these. I learned that since there was no insulin back here pushing this down, there was no fast-acting insulin that was going to drop me suddenly, in my case, that I could wait. I could be patient and wait for that to come up, which I did. And it slowly did come back, of course. Important to note. And that was with no food present, actually. Microcarbing, another basic move. Shelf, and now this is at a low level. I was going to do some work. I didn't want to be right at 70 to 80 all the time, although some of you may be comfortable there. 4 grams, all it was, 4 grams of carbohydrate, and about 15 minutes later, a slow upward trend, which then leveled off in about a half an hour to a new shelf. Again, you have to be patient for this to happen. Okay, there was no insulin in the back. There's no insulin back here that was going to drop me down. Just remember that. So if there were, this would not have been attempted. It would have been something stronger. You have to manage the situation. Okay, you have to manage the situation. Carbohydrate nudge. Okay, now notice that 4 grams here, yes, it did work, and it worked a little bit faster than some of these other examples did because these are variable, and these are all fast-acting carbohydrates. They're candies, or they're juices, or so on, things that I know that work rather quickly. And this went up and made its own little pivot and came on back down. But interestingly enough, just by keeping an eye on this, there was no action here. It leveled back off into a steady range. Didn't have to do anything. Although I could have treated that there, I could have treated that there if I'd wanted to, but the decision was made. I didn't need to. I was at work. I didn't have any pressing physical activities going on, and so I was able to wait that one out. So again, another example of being patient. Okay. Now I can be patient. Sometimes the 13-year-old people can't be. Sometimes adults can't be patient. but when you can, this is one of the benefits you can get from this. Microcarbing, I can give 5 grams of carbohydrates at the same relatively similar levels and get slightly different results. Okay, and have slightly different times for them to work, as you can see in these examples. So it's not a precise art. Nothing about sugar serving is precise in that regard. Double tap pivots. Double tap pivots are when you give a dose of insulin to try to pivot the line, and you just don't see very much of an effect. In this case, I typically give it at least an hour, if not an hour and a half, before I do something. If you want to be totally conservative, wait a full 2 hours, okay, before you act again. So if this had gone up further, would have considered doing another dose here. But in my case, I did it after about an hour and a half. I took another dose, and of course, then brought that back down. I call that a double tap pivot. Now, there's a double pivot that works in either direction, and that is example here. Classic pivot here. 149 took 3 units of Humalog, rapid acting, lag time, pivot, drop, inflection, and instead of dropping too low, I took some carbohydrates. I showed you this earlier. I kind of tapped the brakes, if you will, hit the accelerator here, to tap the brakes over here. And I could have actually done that here higher if I'd wanted to, but I felt comfortable doing it here. And of course, it pivoted back up, back into a steady trend line. We also sometimes call this the same thing as a 2-step pivot. This is when actually I went further than I wanted to, and retrospectively, you could actually say I probably would have been better to treat that one there, but I waited until it got here, took a small corrected dose of carbohydrates here, and pivoted back up. So 2-step pivot, a good example of that. Again, another example of an inflection, a delta wave, classic pivot on the left. Okay, direction affects correction. This is important to remember, very, very important concept. Back in the old days when we just did meters all the time, say we had a blood sugar of 100, okay? Most of us would be just tickled pink to have that, right? On the other hand, in the era of sensing and trending, we know that could either be what we hope it would be a fairly steady trend line, but it could also be part of an ongoing drop or even an ongoing rise in blood sugars. So this speaks itself to the power of a CGM. Remember, when you're learning how to do this pivot move, practice at a high range, at a high level, as I show here. It's like when you learn to drive your first car. You go out in a big parking lot where you're not going to run into anything, hit anybody. You can go at whatever speed you want and practice your moves there. This is like your parking lot to go practice in, a higher level. And if you're going to decide how much do I give for a particular point in space, and I pick either 160, 180, 200, whatever you want to practice from as a starting point, pick it and say, whenever I get it here, I'm going to give X amount of insulin, fast-acting corrective insulin. Now, you can select that from your correction factor, whatever your doctor or your team gave you. Start there, okay, and then see what you get, okay? And if it's not, after several attempts at similar heights, you don't see this effect, you can start adding to it in subsequent attempts until you get to a point that you have some comfort level that at a particular altitude, and I use the word altitude, blood sugar wise, that you can turn that line, okay? Then as you get better at doing this, the altitude at which you actually act gets lower. And I think you can see that in some of my more recent illustrations. I started out practicing at 180 and 140. Those are just my personal preferences. You could do 200 and 150 if you'd like, but I picked 2 of them. And whenever I got close to those values, or I was steady at those values, I would practice correcting from there, okay? Very important skill. It took time, it took patience, but you can get to it. And then now, as I live between primarily 70 to 140, I'm pivoting, if you will, or I'm trying to aim for 100 all the time. Now, that wasn't where I started. And that's why I say you have to be patient, work your way up to this. So just to show you some examples, if I practice my pivoting at lower altitudes and get good at it, then I have less ups, less highs. And over time, those fewer highs translate, if you're concerned about A1Cs, into a lower A1C. So instead of waiting to get to 180, which you don't see me do unless I just don't see it anymore, I'm correcting typically at 140, sometimes even at 120, just depending on the situation, okay? That depends on your comfort level, but you have to start on the high range first, learning how to pivot high before you start pivoting low and tight, okay? So if you're trying to do this just empirically, just by doing as little insulin as possible, pick an altitude. As you can see me here, I'm going to push all these buttons just so you can see the whole range of values. 180, okay? Start with 1 unit, and you don't get much of an effect, or a half unit, whatever the age of your child or you might be. And then start increasing that at each subsequent attempt until you get an idea of what it takes to turn that upward trend line, okay? And then practice that, practice, okay? And again, I did that same thing with 140. And when I first started doing this with the different insulin, it was 6 there and 3 here. I've lost a little bit of weight through a lot of exercise. Now this has now become, because I'm more sensitive, 5 and 2, okay? But this, because it's a constantly shifting landscape here. Just remember, gymnasts, before they can get 4 feet up on a 4-inch beam, have to do a lot of this on floor exercises. Likewise, Olympic divers and competitive divers have fixed points above the water they practice their moves in. Otherwise, they wouldn't hit the water right. So I'm using that same metaphor or analogy for why you pick certain levels to administer insulin at to practice. Like I used the example 140 and 180 for myself, and now, of course, 120 will be in tighter control. Okay, so when you're learning how to drop, you have to be on a steady trend line. By definition, you're going steady. You're on a shelf, right? That's important to remember. You're on a shelf. And then if you want to be conservative about it, just give 1 unit on a shelf and see what it does. Give it at least 2 hours. Give it a couple of hours, because that's what you're supposed to do with any rapid-acting insulin. Wait 2 hours before you judge its effect. And then once you start learning what your range of responses are, you can start increasing the amounts until you know what's appropriate for a certain level of altitude, again, to use that metaphor, okay? So that's how that works. And again, as your skills and confidence grow, you can start lowering the level at which you start doing these actions, and certainly probably using lower dosages, of course. So many times I'll be 120 and I'll take 1 unit of insulin, because I've learned that roughly on a steady trend line, 1 takes me down about 20. So if I want to fall back on a ratio, which I agree is static, there you go. And in fact, you can use this to refine those ratios that somebody else has given to you from some formula off a wall, okay? I'm going to show this last slide. I'm going to ask Jeff to ask the next question next, so Jeff, prepare. This is what happens when you're looking at a drop, okay? And those of you that are in educational psychology know that we have 2 systems. We have our analytical system called System 2, and our intuitive system, System 1. We use System 1 when we're looking at our visual prompts, our heuristics, our drops, our shelves, our delta waves. But as we're watching this drop, our analytical side kicks in, and we start saying to ourselves, what are we going to do at certain levels as it drops? Are we going to continue to let it fall? If so, at what point are we going to take some sort of action lest we get a low? And you can see here, these are some of the possible outcomes with a drop like this. Now, that drop could actually just peter out and go right back up. That would depend on what was causing the drop in the first place. If it was a huge load of carbohydrates and a big dose of insulin to bring it down, and the insulin wears off and the carbohydrates are still there, well, that's going to go back up, right? Because the carbs are outlasting the insulin. On the other hand, maybe enough insulin can be given just to cause it to level out, although that may be at 180, and I may not be happy with that. I could also wait until it came down a bit lower, and if it got past 100 and hadn't dropped, maybe I need to do something like give some carbohydrates to keep it, to bolster it back up and tilt it back up. On the other hand, if it comes down here and starts to level out around 100, that's all I'm going to do is just glance at that. Okay, so this involves primarily watching. That's where I get back to the glancing comment I showed you earlier. Glancing is key. You've got to look. You got to look, and it's just a quick look. Okay, and you know what you're looking for. All right, Jeff, do you want to ask the next question?
Sure. Our next poll is, do you feel diabetes self-care is more of an outcome or a process that is a destination or a journey?
I think I brainwashed everybody already on that one. So
you're a good teacher.
Yeah, keep repeating myself. As this next few slides, I'm going to illustrate some core concepts, and then I think in the remaining time, we'll see what we have left, maybe for some questions.
So 97% of people think it's a journey.
That's it. That's it. It's a journey. It's a process. I completely agree with you. All wonderful. Now, this slide is extremely important for many of you. Okay, I have my pirate hat on now, my Johnny Depp hat. Waiting for the bend. If I have to pick one thing that sugar servers and even non-sugar servers could do better on, and that is learning how to use their CGMs to wait for some visual clue that the insulin they're taking for food is working. And I call that, I give that a catchy phrase in the book called waiting for the bend. A bend, as you know from my previous discussion, is an inflection, and a bend is an inflection. And I've given you three kind of theoretical examples here. Let's take the middle one first. That's your in range. I'm in range. I'm going fairly steady. I'm on a shelf, and I take my insulin dose, and I wait about 15, 20, maybe 30 minutes, sometimes 10 minutes, and I look for any sort of change, a downward inflection in the trend line. When that occurs, that's my cue to eat. Okay. Now, I don't want to overanalyze this too much, but this is also assuming I'm eating a fairly normal meal, not something that's very, very slow, maybe even something that's not very, very fast, but certainly something that's fairly average in terms of its effect on blood sugars. On the lower panel, you can see if I'm already on the downward trend, I'm already trending down to begin with when I take my insulin, there's not going to be as much of a weight, and in some cases there may not be any weight, and in some cases you might even move the insulin after the meal if you're even lower than than 80. So timing is everything. On the other hand, on the top panel, if I'm trending upward and I'm continuing to go up, then it may take more than 20 to 30 minutes for that line to pivot and turn around. This creates a bit of a challenge for a lot of people because you may not, well, outside of right now, we have a lot of time, I guess, but in a lot of situations, we don't have the time to wait between when we take our insulin and when we eat. Sometimes we don't even know how much we're going to take, how much insulin we're going to take, because we don't know what we're going to eat either. I will give you a bit of a tip on this. Some people will give a small starter dose of insulin, and they call it a pre-bolus. The term pre-bolus has come to mean taking your insulin before you eat, 10-15 minutes before. Pre means taking even a smaller dose before that. And then once I know what I'm going to eat, then go ahead and take the rest of the bolus then. So there are all sorts of strategies to mitigate a big spike in blood sugars that occurs after a meal if you don't have the luxury of being able to pre-bolus. So you can take a small portion of the bolus, not enough to cause a big low, but something that will at least buffer the rise in blood sugar from a meal if you're forced to have to take the two right next to each other. Now, that may not work in the cases of a lot of kids in school. I got that when you have 20 minutes to eat, but it can work hopefully at breakfast, and it can hopefully work at dinner time. Microcarbing is, in a way, the opposite of microbolusing, and that's using small amounts of carbohydrates to move the blood sugar up. When you're learning how to do this, if you want to be really proper about it, when you have a low blood sugar, you want to rise up, go ahead and give the standard 15 grams. Now, many of you won't even attempt to try that because you probably intuitively know 15 grams for many of you would shoot you up to 200 or 250. Okay, so many of you are probably already using much smaller amounts of carbohydrates, either 2, 3, 4 grams of carbohydrates to just nudge this line up. Okay, you can see that I do that all the time, along with the small half unit, 1 unit, 1.5, 2 unit insulin boluses as I bump the line before it gets outside 70 or 140 respectively. Inflections are very important. They're telling you something. Okay, that's one of those common structures. Notice that there are 2 inflections here. Okay, the one in the middle is a pivot. Okay, it is a form of inflection, but learning how to recognize these inflections are essential. You have to be able to see them. So if you're here and you look back and you see that makes that delta wave significant. So it's important to be able to recognize an inflection, which represents a significant deviation or change from the preceding time period, as you see there. Okay, these things have meaning. These inflections have a lot of meaning. As I said earlier, the pivot actually occurs because this insulin is starting to kick in and turn that rising trend around. When it inflects back to a shelf a couple of hours later, that's also a reflection of the duration of effect of that insulin dose right there. The inflection here heralded the onset of that delta wave for whatever reason. Now, this delta wave was in the morning, as you can see. I tend to have some stressful mornings, and so this was a stress delta wave. And so I did not need a lot of insulin to turn that around, okay? Now, this is an example I showed just to stymie people a bit. Why are so many different insulin responses? 6 units and 6 units taken just a few hours apart with dramatically different results in that case versus that case. And that's to point out something I said earlier. When the next night looks like this, okay, many people would make the mistake and say, I need to make a bunch of changes here. I need to change basal rates, or I need to change my basal insulin, or maybe I need to get a new dose of insulin, a new bottle of insulin, or a new pen, or something like that. No, that's not the explanation for this one. This was due to the food that was being consumed the night before. In this case, a cheeseburger and onion rings and some fries, okay? That led to about an 8-hour duration of food action, which needed overlapping, you know, as you can see here, doses of insulin to cover them. And I call that in the book, I call it in this slide deck, insulin chaining, okay? I want to make a point for all of you that are saying, oh, he's stacking insulin. That's not stacking. Stacking is indiscriminate. Stacking is you don't care, you're mad, you're upset, you just do something, you stack something. You don't know what you're doing. chaining is a conscious effort. You're doing it based on understanding of what's going on with your blood sugars. Those delta waves, I'm dosing on delta waves. Okay, I'm also mindful of the duration of insulin action effect as well. So mindful of my duration of insulin action and a delta wave and a long-acting food, I can keep those 3 things in my head. I dose supplemental insulin until I found that this one was a bit too far, as you can see. That one took too long. So in this case, next time, if I ever did this again, I would probably take a lot less over here as I get further out from the 8 hours. A lot of the foods I eat that are long-acting, like pizzas and burgers and such, are 8-hour efforts. And so once I get past 8 hours, usually that's past that part of my intestinal tract where it's creating a lot of problems. Let's have a review real quick, okay? These things that I'm highlighting in these light orange are called drops, okay? These things that are red going up, I call delta waves. You have to be able to see these without the machine doing them for you. Hopefully you see them a lot better now. And these periods of relative stability, even though they're not perfectly straight, they stay within a range, but they stay steady, they're called shelves. Those are your 3 big ticket items here. Those things on the arrows are the inflections. They're like the commas, they're like the punctuation marks, like the grammar, if you will, of the other 3. Okay, those are inflections. And of course, a significant change, a total change in direction of the trend line is called a pivot, whether it's due to the action of insulin, due to the action of carbohydrates, or possibly exercise or stress, respectively. But those are plus minus effects. So another quick quiz. I'm just going to show you and ask you rhetorically what this is. What do you see here? Period of stability. Okay. Blood sugar 155, which many of you, maybe you're happy with that. A dose of insulin is given here and a slow reduction, which levels out over on the right. That's called a drop. That's called taking the drop, okay? Core concepts: recognize blood sugar patterns visually and assign significance to them. Remember, you're managing a situation, not just blood sugar, okay? Not just a number, okay? We're all good at managing situations. We do it all our lives, okay? Let's take a couple steps back and we're looking at food, insulin, stress, when we had something done, how much we had. Try to keep it under 7, but we're trying to keep good management over a situation. We can preempt things. We can prevent things from happening. We don't have to let them take us over. If we see things changing, we can make prudent efforts to blunt the rise or blunt the fall in the blood sugars. Those of you with the basal control pumps are actually trying to do that now. They will either increase or decrease the basal insulin delivery. Some of your devices will actually give corrective dosages prophylactically of insulin. Eventually, there will be a pump that will do, as we know, glucagon through a catheter as well, and we'll have something much more akin to a regular pancreas. Remember the concept of chain-dependent insulin dosing, or chaining, as I showed earlier. And I have all this information is listed in a series of 19 lessons on the website sugarsurfing.com. They're very easy reads. You can look at them. If you want to bypass reading the book and just go there, it hits the highlights. Certainly, you're always welcome to get the book or the ebook and look at that. But you can get all this information off the website. It's totally free. It's all there for you. Remember, insulin action is not a constant. Many things change it. Food, stress, and yes, of course, bad insulin, bad pump sites, inappropriate programming of your pump, there's still those other suspects you have to keep in mind. And remember, in the end, you're steering a trend. You're not just reacting to a number, okay? Jeff, it's 3:10. I guess it's 4:10 where you're at. And if we're going to have time for questions, let me just say in closing that I have several more slides which highlight a number of situations that you can look at and use the skills I've given you so far to review in the slide deck that Jeff Hitchcock is sharing with you. Okay, I believe it's in a handout form as well as the slides themselves. Either way, you'll have access to the full slide deck that I've shown you, plus some additional bonus material that's in there as well. Okay, keep in mind that these workshops that I do live, for those of you that have attended them, usually run for about 2.5 hours. And so the material I'm trying to cover is a lot, I agree. But I'm glad to know that a significant percentage of you guys are already doing this stuff. So maybe I can address in the remaining time we have the questions that you all have specifically, and I'll do my best to answer them. Remember, sugar serving is not a panacea. It is not a panacea. It's just a way of solving problems using information that you're getting from your continuous glucose monitoring device. Okay, so I want to thank you all for your attendance, and I'll be happy to take questions. Is there one last question for the audience, Jeff?
There is. Do you learn more from setbacks or success?
Do you learn more from setbacks or success? While you're filling that out, I've had diabetes for coming on 55 years now. I've had it for 55 years. And most of the things I teach my patients in the clinic and at workshops are things that I've learned through experience. And I think we all know that experience is a great teacher.
Yeah, so it's about 81% say setbacks are their better teacher.
That's the stuff we remember. It really is. It really is.
All right. So Steve, let me go to some of the questions that we've received. We received a couple via email. How does gastroparesis and/or dumping syndrome work with sugar surfing?
Well, anything that alters the rate of emptying of food into the stomach can require modification in the timing of these actions. I think individuals that have gastroparesis or dumping syndromes are often better off using insulin pumps than with injected insulin, because it gives them a little bit more flexibility in terms of how they work. Stomach emptying can be very erratic, no question about that. It's another variable we have to deal with. Even those of us that don't have gastroparesis, just by nature of the foods we eat, the composition of those foods will slow down or speed up how fast the stomach's empty and push that food into the early part of the digestive tract, which is where most of the absorption of sugar occurs from. So it becomes a variable you have to navigate. But the sensors are the best thing to use for this. They will show you, they will give you the secret of what you need to do, because you'll see the patterns and you can modify your behaviors accordingly. So many of the things we talked about, yes, you may need to delay things longer, maybe an insulin dosaging longer than you normally would if you didn't have gastroparesis.
All right. Question from Kelly. What are your thoughts on using a tandem control IQ in conjunction with sugar surfing? Would it complicate it or negate it?
I think it's great. I think it's great. I showed you, the reason I showed you some of those clarity reports earlier were that 3 of those individuals were on the control IQ tandem pump, yet they still had out of range blood sugars. A lot of that speaks to, now keep in mind I'm working with kids and teenagers, and we all know that sometimes they don't always stick with the program. And what I showed there was those pumps were trying to bring those high blood sugars down overnight by adjusting the basal rate upward. That's wonderful. And it gets them back into range very nicely during the day. But once they start doing their personal behaviors or lack thereof, you start seeing a lot of variability. So the principles of sugar serving still apply whether you're using these devices, because once you're in your range, your blood sugar range, that pump, that device just lets the pump do its thing the way it's programmed to do. Only when it starts to predict you're going to deviate from the range that you want to be in will it step in and do something for you. It's a lot like my hybrid car that has a steering control system, my Honda. If I take my hands off the wheel, it starts to drift outside the lane. It'll actually steer my car back in, and it'll say immediately, put your hands on the wheel and steer the car. Okay, so it's not unlike that technology. The pump user still has to be engaged. In fact, if anything, you need to be more engaged. You have to still be very good at counting your carbohydrates, understanding what kind of carbohydrates they are, time your insulin dosing better. Those are all things that still benefit people on these high-tech pumps.
Very good. A question from Barb. Do you use proteins after carbohydrates when treating lows?
Yes, I have, and I think the nature of that question is sometimes proteins can give a more sustained effect on blood sugar for some people. Again, given the fact that we're all different, I point this out, and I didn't talk to that in this discussion, but I have friends, and there are probably people on this call, where protein will actually sometimes drive their blood sugars up rather wildly. One thing specifically is eggs. There's some people out there, friends of mine, who scrambled eggs will push them through the roof, push them up 200 points, whereas I can eat scrambled eggs and I'm flatline. So I think we're going to all find that because of our unique constitutions, that protein affects us differently, and even from event to event, it can be slightly different. This morning I had nothing but protein, but I still had a slow rise in my blood sugar. I've done the same thing in the past and had nothing but stability in a shelf. So it just speaks to the need to keep glancing. There's an expected response, and then there's what really happens. That gets back to the core concept of sugar surfing. Half of my day is what I planned, the other half is what I have to react to. And I've never had it be 100% line up exactly the way I planned it.
Very good. Question from Kinga. How often can I make corrections? Do I wait 3 hours between each correction?
Excellent question. The standard rule of thumb for doing any correction in any model is at least 2 hours, okay? Now, I've shown you examples of an advanced application. You saw me doing some insulin dosages that are a lot closer together. When I do that, I'm doing it based on the knowledge of what I've eaten, again, managing a situation, what I've eaten, how much I took, and my understanding of that food, plus a commitment, a total commitment to follow through over the next 2 or 3 hours to make sure I follow that trend line. If it goes up and pivots and starts to drop down more quickly, I'm going to step in and intervene, apply a carbohydrate break, if you will, a fast-acting carbohydrate break to prevent that from dropping me into a hypoglycemic range. The same thing would happen if an insulin pump that had an automatic control system involved with it would do the same thing. If for whatever reason it gave you too much insulin or the effect was too strong, it would step in with a countermeasure to raise your blood sugar. And that will happen. I think everyone here that attends Jeff's conferences knows that those technologies are in the works and or in development right now. And that's how the system works. That's how your body works as well. So you can do that in a manual fashion, as I just described.
All right. A question from Leslie. How do you recommend handling growth spurts and hormones on kids hitting puberty with sugar surfing? Some of those highs can be very stubborn.
Absolutely can. And I totally feel your pain in that regard. They can seem to be erratic as well. Some days you can have fairly steady overnight readings. Others you can have rises that occur at about 5, 6 o'clock in the morning. Even in my own life, and I'm not growing anymore, of course, if anything, I'm shrinking. But depending on what I'm looking forward to during the day, I'll have a rise in my blood sugar. One thing you can't separate out from this is stress effect. I'll give you just an example of that, and I'm not saying this applies to your case, Leslie, but we had a young man in our practice who was constantly going up into the 300s mid-morning on school days, but not on holidays or weekends. And after a little bit of investigation, what we discovered was being in 5th grade compared to 4th grade, he was being asked to read in front of the class. And we actually discovered he had dyslexia based on that. We didn't know that until then. He got extremely nervous and self-conscious and anxious about having to do that. And it drove his blood sugar up from 120 to 300 within an hour or so. It's not unlike the baseball player who's out there in left field waiting to catch the winning ball, and the mom may be watching that center track and seeing it shoot up to 300. He's not doing anything but standing out there, just in anticipation and the anxiety. So you've got that on top of that too. But if that's not the issue, then if you start seeing a delta wave, a rise, then increased basal delivery, especially now that we have these basal control pumps, usually does a pretty good job of catching up with that, is my experience. But if you're not using one of those basal controlled pumps, you would have to make a decision at some point to correct that with a bolus of insulin, much like I've shown you earlier. maybe a small mini bolus at first until you got a feel for what's necessary and what your threshold for action would be. Maybe it's 150, maybe it's 175, maybe it's 200 at the beginning, depending on where you started from.
So here's a question from Nancy. Can you comment on the effect of coffee on blood sugar? Even with black coffee, I see a rise.
Again, back to my egg comment. I drink black coffee. I blink it all the time, and my blood sugar is flatline. So that's my physiology. But I totally respect that people can drink black coffee. They can have an egg and nothing else, and the blood sugars can go up. There's a lot more at play in what regulates our blood sugar than just insulin and carbohydrates. There are lots of other forces that we, quite frankly, don't have a lot of control over. We just have to respond to them. And I put that in that category of reactiveness. I have to react to that. If I see an unexpected result, even though it's not happened in the previous 10 experiences, I still have to respond to it. I can look at it in disbelief, I guess, at first, but I still have to do something. And if it's just a stress rise of some sort, then I usually am more conservative in my actions, as opposed to if I know it's being driven up by food. If it's just a sudden unexplained rise, I might even go as far as verifying that with a blood glucose meter just to make sure that's what it is and possibly not some sort of sensor error. But I sometimes have to respond to things that are not terribly explicable. But if that's a pattern for you, Nancy, and it happens to you regularly, then by all means, you should develop a method for managing that.
So we had a question about sharing your experience transitioning from an insulin pump to MDI and whether you would consider going back on an insulin pump.
I get that question all the time. I was on a pump for 35 years, just about every pump you can imagine. And then I got on a sensor, and I was wearing a pump and a sensor, and I wrote the book a few years ago with experience from both. And I just did a personal experiment, and I said, well, can I do just as well with just my wits and a long-acting insulin and fast-acting insulin? And that's been my journey for the last several years. I have no qualms in going back on a pump. I love pumps. I lots and lots of boys and girls on pumps, and I think they're the greatest thing in the world. And I might go back on one someday myself. Maybe when some of these newer pumps come out, I probably could do better. For some reason, I like doing it this way. I had a friend one time who I always used to argue with him, why don't you drive a car with an automatic transmission? Why do you go to the trouble of shifting all the time? And he said, I like the control I have over my vehicle. And I didn't really appreciate that in my youth, but I do now. And so in the end, sugar surfing is not about an A1C. It's about having a sense of control over something that many of us feel has dominance or control over us. And while I don't have 100% control over it, I feel like I have a fighting chance against it now with a CGM technology, which I didn't have before with meters. And that's the game changer for me, is to be able to see that information, make my own decisions, make my own choices. And that's empowering as an individual who's lived with this for 55 years.
So we've got two more polls, and your comment about how long you've been living brings up this one. How long has you been living with type 1 or living with or managing diabetes?
Great question. How many people out there have been living with it longer than me? You guys,
well, we only have 5 options, so 31 or more is the upper end.
Well, 31 inspires me too. So yeah, as somebody who's lived with it for 55 years, I'm always happy to see people who are pushing the 75-year mark. Our good friend Richard Vaughn, we all know him, wonderful man. He inspires me, how he's lived his life. There are many others like him out there who I look up to, and I'm sure many of you do as well.
So 55% are less than 5 years, and then a kind of an equal amount in the other groups. Okay. And then we have our last poll, which is probably the most important.
Yes.
What was your favorite hat?
Which favorite hat? I think I hit them all. Yeah, I got them all on. So I have 150 hats, by the way. That may be the toughest question of all.
I think we've got people with a lot of varied views here. All right, so let's close this off because the boat's slowing down. And It was pretty much even, about 20% for each.
Oh, that's good. That's good. That's good. Like I said, I have 150 hats, so and I wear different hats all the time when I see my patients. Well, I want to thank you,
Let me
Jeff.
just address a couple of questions. Several people have asked if this is going to be recorded and available. Some came in late. This entire webinar has been recorded. We will have it online on the Children with Diabetes website by tomorrow. And you can find it at cwd.is, like cwd.is, and we'll have it right there on the main site. And Steve will have links to your sugar surfing for people who are interested in learning more about this incredible process.
Absolutely. Thank you very much for everything, Jeff. Any information people would like to have on the, if I can get to my slide, sugarsurfing.com has all the information that you'd like and access to a book if you like that. Everything's there.
And we'll have this information on our website along with downloads of the slide decks that you included in here.
Thank you so much.
That concludes our first Screenside Chat with Children with Diabetes on our guest, Dr. Stephen Ponder on sugar surfing. Thank you very much. Have a good afternoon, everyone.
Bye-bye, folks. Thank you all. Bless you.